All right, here we are. Alberta Impact. I better turn my phone off here. Alberta Impact Uncut. We've got Reg Joseph, Health City, who's come in to join us today. So super thankful for you to come in and have a conversation with us. A real conversation about healthcare and all the cool things that are happening about healthcare when it comes to virtual health, when it comes to policies, when it comes to all sorts of really unique things that are coming out of here in Alberta, more specifically Edmonton. Super cool stuff. So, Reg Joseph. Who is Reg Joseph? Let's start there.
Sure thing. Bryce, a real pleasure to be here and looking forward to this conversation. Who's Reg Joseph? I'm, as you know, I'm the CEO of Health City. Been sort of in the health arena for all of my career.
Yeah.
So
except your Dairy Queen days. I'm going to pull out some stories here.
Hey, I was head fry guy at Dairy Queen in my teens, and taught me about real work and elbow grease and all kinds of other grease.
Yeah, absolutely. So when you say you're in the health arena, like where did that kind of start? So let's go back to Dairy Queen. You're a young, ambitious lad moving through the world. You finish up high school, and then where do you go from there?
Yeah, so I head off to university. I wanted to be a scientist. That is what I wanted to do.
Cool.
I wanted to be one of those guys that works in the back of the lab and figures out the cure for cancer. So that was bright-eyed, bushy-tailed Reg going into school. And so I ended up doing undergrad in physiology pharmacology, and realized as I was applying for grad school, because I was still going to pursue that academic route, a lot of my friends convinced me to say, you know what, I don't think this is you. I think you need to look at the business side of things as well. And so another story, but a bit of a dare, I decided to write my GMAT and do my MBA.
Wow. Very cool. And so when you got your MBA, and then now health seems to have been always ingrained in you, because it seems like from scientists, you said right off the bat, you wanted to cure cancer. Health was kind of your thing. So why the passion in there? Is just something a major interest? Was there?
Yeah, originally the interest, to be frank, was the science of it. We were. At the time when I was just finishing up high school, I had a biology teacher that really motivated me. And there was a lot of new breakthroughs coming in health around that time. And I just thought this seems like a really exciting area. And as I mentioned, wanted to be a scientist. And so I thought, this is the path for me. This is where I want to go. There's a lot of fun stuff that's happening. Mm-hmm. This is a growth area. This is exciting. So that's what started it.
And so then you kind of diverged a little bit, went into business. So now let's take us up to Health City. You're the CEO of Health City. Take us through what that is. What is Health City exactly?
So what's happening is, and Bryce, you and I have talked about this before, there are some huge transformations happening in other sectors around the world. Mm-hmm. So we've seen the changes that are happening in media, for example. Very few people use cable anymore. We stream everything, right? Yeah. Transportation is a great example with Lyft and Uber. Banking, another great example. I can text you money where I couldn't do that a couple of years ago.
Yeah.
Well, those changes, interestingly enough, are already happening in health around the world. Mm-hmm. They're not happening in Canada. Mm-hmm. And that is sort of where I get on my soapbox a little bit, is there's no reason why it can't happen in Canada. We have a lot of the intellectual capacity. We have dedicated clinicians in the field. We have a wonderful health system. We should be able to make this happen in Canada as well. And so that's where I've switched now from sort of the interest on the science side of health and really more health as a system. How can we transform healthcare? Mm-hmm. And that's what Health City is all about, is how do we transform healthcare to the next generation where we can provide health to all the citizens in Canada in an affordable and effective way. Mm-hmm. And one of those key initiatives that's going to drive that is innovation. Mm-hmm. It's not the only one. We're going to need some policy support. We're going to need some cultural change. There's a few other things that we're going to need to make that work. Mm-hmm. But innovation is a key driver for that. And the ability to adopt that innovation is what is going to drive us forward. So that's where Health City is really focusing, is how do we transform the healthcare industry. Mm-hmm. Now, on the back end of that, where we see a real opportunity is the innovations that are going to transform healthcare, they're being developed here. And Bryce, you highlighted a lot of these companies on your show, both on Alberta Impact and the Future of Health, on the wonderful innovations that are happening right here in our province. So we have the ability to do that here. Let's do it.
Yeah.
And so I see a double win here. We can not only transform healthcare, which is going to provide better health for us as citizens, but also is going to be an economic driver for us and be part of our economic diversification strategy for our city, our province, and our country.
So we've looked a little bit to the future with that bit of conversation. So I want to go back a little bit. The buzzword is crisis. We're in a healthcare crisis right now.
Absolutely.
So what exactly, in your perspective, does that make it a crisis? And where did we cross the line where it became a crisis?
So the reason why it's a crisis is what we're realizing is more and more dollars that we put into even just basic operations, we're not seeing any step changes in health. We're treading water and we're just barely keeping up. The problem is that cost keeps rising, 3 to 6% a year. It keeps rising. And if you look at provinces across Canada, most provinces are getting close to 50% of the annual budget is being spent on health.
Wow.
And so that's why it's a crisis. When policymakers are trying to make decisions on whether to build roads, whether to build schools, or just keep the health system operating, that's a crisis.
Right. So where does the narrative change for policymakers where, I know Health City comes in and says, hey, you guys, we got to start looking at these options. There's other options out there. They're sustainable. Like you said, we're treading water. We can't, that's just not sustainable. When your population keeps growing, but your dollars stay the same, it just doesn't work. So in that narrative, where does the transition come from a policymaker's decision to, what direction does the policymaker go into to start supporting initiatives that change something that they're so used to for so long?
Yeah, it's a really good question, and I'm not too sure if I have the right answer for you, but I'll give you a couple of ideas. One is looking at the fact that health, we have to look at it as a big picture. So other jurisdictions do this, particularly our Nordic friends. When we look at Denmark, Norway, Sweden, Finland, they have figured out that the impact that we can play at the municipal level and at the state or provincial level and at the national level, it's all connected. So when they look at health, they say, how do we tie in the cities? How do we tie in social programs? And it's a robust approach that they're looking at because they know that all these aspects impact health. So Norway is a great example. They're holding the line in terms of how much they're spending on acute care because they're putting a lot more of their dollars up front into the prevention side of things. So that's one area we need to look at. And we have robust systems and capabilities on the social services side, on the municipal side that we need to be tapping into. But what that requires, which is hard, it's both a cultural change and a policy change, is how do we work together with provinces, with the municipalities, and at a federal level to get us all to work together towards this crisis.
Gotcha.
So that's another one. Another initiative which is near and dear to my heart is all these innovations that you highlight on your show, Bryce. How do we get those to impact Canadians? So, I can tell you there's a number of folks that I talk to on a regular basis who say, you know what, we're actually tired of seeing those cool medical story news items. We see it on Global or CBC, and there's a scientist who says, hey, I've got the new cure for XYZ, and trials are starting, and then you never hear about it again.
Yeah.
And I can tell you a lot of people have come back to me and said, why don't we ever hear about those again? What's happening? Well, what's happening is that our system, which is developed to protect the patient, right? Yep. It's how do we do no harm, right? So how do we adopt things that do no harm? There are processes in place. There's policies in place to make sure that doesn't happen. There's regulatory approval for products. So we have all these systems in place to prevent that from hurting the patient. But what's happening is that those systems are now so conservative that it's indirectly it's hurting us. That's exactly it. Yeah. And so we need to now figure out and say, okay, well, you know what? The world is changing. those systems worked really well
Yeah.
in the post-war period, 50 to into the 80s. But then after that, it's a brand new world now. And so how do we start getting smarter about health like we did around transportation, like we did around banking, like we did even around education? We're getting smarter. How does health change with the times as well? So that's another area that we have to figure out. How do we bring in these new innovations in a safe way,
Yeah.
but in a way that's meaningful, when even the patients are saying, hey, look, I'd like to try this. I'm willing to do this. How can we do that in a safe way and get that to them, right?
And we talk about, like you mentioned, a really good point, cultural change. People, and like there's like this stigma with technology. There's a stigma with data and information right now that needs to be broken. And a lot of the people that we are highlighting with Future of Health and Alberta Impact are bringing up these technologies that are kind of require a lot of that shared data and the willingness of the people who are concerned about their own health to share their data. And we talk about like Colin Murphy, we talk about Raj Pedwell with MMHG.
Right.
One of the conversations I've had with these guys is kind of where this whole health system is going. Is it going to remain I mean, we are a publicly funded. I mean, it's not free. It's taxpayers' dollars.
Absolutely.
At the end of the day, and we give those dollars to a larger system that gives us the services that we need or help push that, right? A lot of people have talked about like Apple, and I want to kind of go into and explore that a little bit. Where are we getting to a phase, or are we going to have to start making decisions where these mass corporations like Apple, where people are already giving their data away, they're giving their heart rate, they're giving that information away, and then we know that there's some plays starting to be made, over on the other side of the border in regards to this massive conglomerate of healthcare providing. Is that a decision that's going to start? I guess this is more of an opinion I'm looking for from you.
Right.
Is that a decision that's going to start affecting us? Is that something that we're going to have to start looking at as a reality, that the way healthcare is today in 10 years ain't going to be the picture anymore?
Yeah, you're right, Bryce. I mean, things are changing. And again, if I go back to all the other sectors, all those sectors have changed. And so there's no reason why health wouldn't change as well. Couple of points on that. The first one is, a lot of the technologies that we're talking about here locally in Alberta, for example, we're not really talking about releasing data out anywhere.
Right.
In most of these cases, these are clinicians who are already stewards of the data. And what we really need to do is have the health system use the data that they already have to drive better health outcomes.
Right.
When I talk to the average person on the street, they think that that's what we're already doing. Right. So for a Cole Murphy to actually use the data that him and his physician colleagues are using to drive better health outcomes, that's what they're expecting from us to do already.
It's kind of a no-brainer. Like really, like when you start looking at the whole picture, it's a no-brainer. Like that has to happen. Raj Podwell talked a lot about giving healthcare back to the individual.
Right.
Putting it in their hands and making them a little bit more, not necessarily responsible for it, but understanding it better.
So let me talk about that in a second. But the idea of these clinicians using data, the challenge there is not now about access, but it is about sort of the systems that we have in the background. So can a physician like Cole Murphy with other physicians together get the right access that they need beyond just the data sets that they have to be able to drive better outcomes? So that's another piece that they've got to work on, that their companies won't be able to do. That's dependent on the system a little bit, and that's where they need some help and change. Now,
so sorry, when you talk access, are we talking like technical access? Are we talking?
It's really about the fact that our systems have been built consecutively over time, right? And so the ability for somebody to access a database that's located in a different location that has a different data set, it's not that a physician doesn't have the ability to get it. It's the technical hurdles.
It's just so difficult.
It could be difficult. It could be expensive. There could be certain kinds of firewalls in place, or just protocols.
Just got all these different. We call it silos. We've used that word a lot.
Absolutely.
We've got all these different silos everywhere. None of them are able to communicate with each other, and they really need to communicate each other if we want to get out of this dinosaur era. I liked in one of your things where like, hey, we use fax machines nowadays. Like, my kid doesn't even know what a fax machine is. Like, and my kid, 5 years old now, in 10 years, I sure as heck hope she doesn't know what a fax machine is. But that those barriers, those silos, got to come down.
Right.
I interrupted you because you were going in a direction, and I might have deviated.
No, it's
from
fine.
That direction was.
So that's the first step, which is how do we create an environment in the back-end systems of our health system to enable clinicians like Combe and like Raj Podwell and others to be able to drive these better health outcomes. But now the other piece that you've tapped in on, which is really interesting, is we own our own data. Mm-hmm. So, when you look at sort of the laws and how they're drafted, we as individuals own our data, but it's actually challenging for us to access our data.
Crazy, right?
So that's the interesting thing that's happening on an individual basis. When you start talking about Apple and Google and even Amazon now is starting to look at health, that as individuals now, we may start to say, okay, well, look, I know and trust these companies, perhaps because I've used them. And you know what? I'm actually more concerned about my RSP data getting out than my urine data.
Blood pressure.
Yeah,
exactly.
Right? And so as individuals now, would we be more inclined to say, look, I'm going to get value from this Google app that's going to help me manage myself and let me be in control over where my health is going to go? That's going to be an interesting disruption to the system that we are not set up for, Bryce, from a policy perspective, right? How are we going to deal with that? Because at some point in time, even if we choose to drive things individually on our own, with the data that we can collect on our own and share that with companies, at some point we need to touch the health system.
Yeah.
So how do we bring that together?
Yeah.
Right? And we're not set up for that. We are honestly setting up policies for today. We're barely keeping up, let alone for what's happening tomorrow.
Right.
And I'll give you a great example. There was a large research-based institution that I spoke to probably about 5 to 6 years ago who told me undoubtedly that there's no way that they would ever move to a Gmail type system because the control that they needed over the data for their own research institution, for the students that go to that institution, they would not want to move in that direction at all. They would always internally manage it.
Yeah.
2 years after they said that, the whole system went to Gmail. Just because at some point in time, you start looking at what is the value provided back to the user, what is the cost is it going to take for me to provide that value, and what am I giving up, if anything, on security. So what's interesting enough is that when these companies start getting mature, those research institutions looked at that and said, actually, Gmail is more secure than what we're able to offer. So you know what?
And that 10 times more affordable.
And 10 times more affordable. Yeah. So my theory on that is this is where health is going to go.
Right.
I am not going to be surprised if companies like Amazon, like Google, like Apple will come to jurisdictions, and they already are coming to different jurisdictions and saying, look, we will help you manage hypertension in your nation state. We will help you manage diabetes. Here's how we think we can do it from a cost structure. Here's the data that backs up how we think we're going to move it down forward. And there's going to be times when these countries, these nations, these provinces, states will come back and say, you know what? We can't do it as effective as you can. So we'll give you the contract. But to me, that's not any different than other contracts that we already do today.
Not at all.
Right? And so
it's just how we're looking at it. We just got to change the way we're looking at how some of these things are being presented.
We can all, if at any point in time we don't feel that an organization is fulfilling their contract needs, you cancel the contract.
Yeah.
That's how it works. That's how it works for every other contract that we do. And I can assure you that we have hundreds of thousands of contracts that the health system makes with companies every day.
Yeah.
Right? So it's going to be a different way of looking at that, and it's really going to be disruptive. And so the question that I have is, coming back to policy, are we ready for that onslaught of change and disruption that's going to come to the system, do we have the policymakers in place looking forward to say, here's where this is going. How are we going to deal with this?
Yeah.
Right?
Yeah. And then where does it go from the future? Like having a policymaker that's not writing a policy for today, but for like 10, 15, 20 years into the future, that still has, you don't want to lock these policies off too much where you can't adapt.
Right.
Because that's kind of why we're in the problem we're at right now. Those policies are not adaptable and they're not being open to adaptation. We really focus on virtual care.
Right.
We've really been looking at a lot of that stuff, and that's a lot of the stuff that we're talking about right now when we talk about, Raj Padwell, Colin Murphy, these guys that are coming up with these digital platforms that you can do right from your phone. You can dial up a physician, almost instantaneously and get access to your information and the information you need, or even like a diagnosis and your blood pressure, all these really cool things. Is there a big pushback? And I know in some of the conversation that I've been having with individuals that are more frontline, so your nurses and your doctors, is there a pushback or a fear that is out there right now, or a stigma for growth in technology and the disruption that technology is going to bring when it comes to like jobs and when it comes to, we're so used to this process. I went to school to be a nurse and this and that and this. That's what I do. If this comes out, and we've looked at some of these technologies, and it doesn't make them obsolete. It just, and I've tried explaining this to some people because of the knowledge that I have, what little knowledge I have, but it's no, this is a tool to alleviate the pressures that you're facing right now when you're doing a 12, 14, 16-hour shift because you're just bombarded with these people. Is there still a pushback that you feel on your guys' end, especially from Health City and the ecosystem that you're in? Are you seeing a pushback?
The pushback is interesting. So it's, I think it's played up by sometimes in the media, sometimes in other venues. But, when I talk to frontline clinicians, they're users of technology on their regular basis, right? So I'm talking to nurse practitioners, I'm talking to LPNs, RNs, physicians who are saying, you know what, it would be great if I'm able to, if a patient's able to give me a quick call and I could, correct them on their dose or correct them on something that they need to do or check in with them on something. It'd be easier for me, it'd be easier for them. We just need the back end systems for that.
Right.
I think that there is some fear mongering around because you'll hear stats about, X percentage of jobs that exist today won't exist 20 years from now. And sure, that scares people, but we have to see that we've already gone through these changes.
Yeah.
So, you brought up earlier, Bryce, the fax machine. So you have an admin assistant that was working in an office environment 20 years ago, maybe faxed things, right? But now that individual is able to do that far more effectively because instead of sending 100 faxes, right? Because that's what
dial-up.
that's what we would do on dial-up
Yep.
to 100 different phone numbers.
Yeah.
You can actually just do a global email, send to everybody on the list to 100 people at the same time. It's the same admin assistant. What's going to happen though is that because that job, which probably used to take a day, now takes 5 minutes, that admin assistant can actually add value in other ways.
Yeah,
and that's how I see technology is going to help us. And that's how it's been happening. And when we look at the computer revolution, it's the same thing that's going to happen with AI. It's going to make us to be able to do more valuable work. It's not necessarily going to get rid of jobs, but it will get rid of certain tasks.
Yes.
Right? And certain tasks that we do in jobs will get a lot easier. So there's a great example. I think Jason Pincock might have talked about this when he was talking about his incubator and some of the work that he's doing at Dynalife.
Yes.
Where they're working with AltaML to screen samples for colon cancer, right? Right now, you've got a very expensive pathologist that's looking at every sample, and a number of those samples are negative.
Yeah.
Well, if you had a computer helping just to rule out what are the negative ones, and then allow the pathologist to look at the more complicated ones, you're saving a lot of time, right? And that is a relatively, I'm not going to say easy, but it is straightforward to be able to make that determination between saying this cell type does not exist. So that's a clean sample. So instead of paying a pathologist hundreds of dollars an hour to look at that, just run that through a system and then focus on the ones that require that pathologist to be able to look at that, analyze it. And so now, again,
it's effectiveness,
it's
efficiency.
effectiveness. You're
It's
not
effectiveness
getting
and
you're not
efficiency.
getting rid of the pathologist.
Right.
What you're doing is you're making the pathologist far more effective.
Yeah.
In any
And turning results over faster.
turning results
Because they're not
over
wasting their
faster.
time with a bunch of negatives. They're getting right to the source,
And on
right to the
any
point.
field in health right now, there is a lineup.
Yeah.
Right? There's a lineup
out the
for
door.
imaging. There's a lineup for surgeries. There's a lineup for this. There's a lineup for that. So I can tell you that none of these people that are working in healthcare, they're not going to lose their jobs. The demand is there. They're just going to end up being far more effective. So the answer is, one, I don't think they're going to lose their jobs. Two, they're going to be far more effective. The folks that I'm speaking to in the field, they want the technology to come into play. They really do, because they feel that they can provide better care and better access to their patients.
Yes.
That's what they want to do. That's why they joined this career in the first place, to
Yes.
provide care and access to their patients, right?
Yeah,
That's what they want to do. If
They all want to
technology-
make a difference.
They do.
A
They
positive
absolutely do.
difference.
Yep.
And they're kind of at a wall right now. And until we get over that wall, and we're talking about that solution right now with innovation.
Yep.
Technology and innovation, utilizing and creating the tools that help and make us get over that wall.
So let
Building
me-
the ladder.
Let me jump to policy, for example. You know, and Alberta has done some really neat things. We were the first province in Canada to unify under one health authority. We still stand out in the nation in terms of the rights and the scope of practice that pharmacists have. And so where we fall, though, is using that to its maximum. So we've got now pharmacists in Alberta have a larger scope of practice than pharmacists in any other region of Canada. We have a health crisis. So is there anybody looking at how do we utilize the pharmacists that are at your Rexall, your Shoppers Drug Mart, which is 2 or 3 blocks from where you live most of the times, and they have hours that are quite convenient.
Yep.
How do we use those pharmacists more effectively in community-based care? Right? They already have the scope of practice, so we don't even have to change that. But can we start looking at them and say, okay, well, look, they're already educated in here. They've got the certificates to do this, this, and this, and this. Can we bring them into the health arena more so that they're not just working on the therapeutic distribution side, but they're also looking at helping manage patients who have already been seen by a physician, who already have a diagnosis, and who are managing a chronic disease? When you think about it, your pharmacist actually sees you more often, right?
Yeah.
And so what's interesting, I'll just give you a little bit of tidbit. You know, I always love to bring my kids into it. When my kids get a cold, they want to see Kevin, who's the pharmacist, because they know Kevin. He works in our neighborhood. He knows our family. He's who we go to when we need to get vaccinations. My kids trust him. And Kevin is very good because he understands his scope of practice. So he would say, well, look, this is not something you need to see a doctor about. Take this. If the symptoms don't change, highly recommend you go see a physician. Or if this happens, see a physician, right? But
and they're of qualification already to give that recommendation.
They do.
So utilize it.
So utilize them. And he knows us. He knows our family. He knows our environment. He knows a lot about us, much like the family physician used to know folks 30, 40 years ago, right? So our first line is, let's go see Kevin first, right? And then he'll kind of guide us to where we need to go. Well, can we more formally use that in a system to effectively deliver care? How do we use Kevin better?
Yeah.
Right?
Yeah. So with the, and I'm actually kind of curious about that comment, is have we seen a drop in local physicians? Like, you know, like your small clinics? Have we seen a drop in numbers of those over the years?
You know, I don't think I'm knowledgeable enough to speak on that. I think that I do know that as the population is growing, it definitely feels that the workload on the average family community-based physician seems to be ever growing.
Right.
And I'm not too sure if that's,
because of that shrink, or if it's just the population's outpacing your growth of your family physicians.
I do know that, a lot of folks that are in medical school are electing not to choose family practice as their choice of specialty, and so that might be part of the challenge. But
Yeah.
yeah, definitely it feels like access to family physicians and time that you get with family physicians is far less than it used to be.
I'm so out of touch because I grew up small town, so we had there was like I think 2 doctors' offices in our town, and they were just like no bigger than our house, and it was 3-4 rooms in there, and you just go in and see Dr. Bauer or whoever, and you'd
Right.
have get your and that was just small town community. But in the city, I'm kind of out of touch. We have our local physician who we go see as a family doctor. But most of the people I talk to nowadays, they go straight, like if there's a problem, they go straight to ER.
Yeah, either ER or they go to these urgent care, these clinics, right?
Right.
Which also has some of its challenges because you don't have that one-on-one relationship. So you don't have a clinician that sort of knows your history because when you go there, it'll be whoever's on shift that day.
Yes.
Right. And so that continuity of care and our systems in the background are not as well connected.
And that's where
for
we're
them
gonna
to
go.
have the history as well. Right. And
Yeah.
so that's also a challenge.
Well, they're not talking to each other because if I go see this clinic over here to get a diagnosis for something, and then I go see this clinic over here, these 2 clinics aren't necessarily talking to each other. Am I correct on that?
There are systems right now, through Netcare and other mechanisms where people can, but the challenge there is that is everybody using that system to its max? Are
Gotcha.
people putting in all the right notes in there and so forth, right? Because again, a lot of our clinicians are really pressed for time, and so they're trying to see you and get a diagnosis and get a recommendation out to you as quickly as possible. They often don't have the time to kind of walk through sort of the entire complexity that you might be dealing with to go through that. And so they might even have the data, but they won't have time to necessarily look at it all the time, right? So,
Gotcha. Okay, so bringing it back to Health City now, and we talk about collaboration, we talk about awareness and bringing awareness to the ecosystem that there's these different innovations that are happening and that they need to be taken a look at and they need to be recognized. And in most cases, from what I can tell, they need to be implemented.
Right.
Because there isn't kind of a question about it. It's more about just let's get it done kind of scenario. Like in a lot of these cases, they might need to go through a little bit of policy like we've talked about just to make sure things are on the up and up. But in most cases that we've looked at so far with the innovation technology, these are kind of no-brainers. Like let's get this done because this is going to fix maybe not all the problem, but it's going to definitely help and alleviate. So from a Health City perspective, what do you need as an organization that's helping other organizations get the job done, get us to the next level? Let's get to the future where we started our conversation. Where do we need to go next to get to that future?
Yeah, that's a really good question. I think a couple of things that we need is first we need to have a system that is more willing to adopt these innovations. And so how do we figure out a system where we can safely test and validate these systems so that patients can use them and we can bring them in and scale them up? That's really what it comes down to. And there's a lot of times when, and I can tell you, both the companies, Health City or the innovators, none of these groups want to bypass any of the sort of check boxes that we would need to do because everybody believes in patient safety.
Yeah.
But there are so many other hurdles and silos, as you said, Bryce, that have nothing to do with patient safety. It just has to do with the archaic systems that we have in play that sort of prevent these technologies from coming forward. So one of the things that I would need is I think it's less a policy change, Bryce, and it's a culture change of saying, okay, here we've got an opportunity to bring in a new innovation. Let's test it.
Yeah.
Let's see if this works. We have systems to do that. We've been doing this for years. So let's test it. And how do we do that in an effective way so we can make a determination? I'll be the first to say that technologies that are coming forward, whether they're local companies or international companies or multinational companies, they all need to be tested.
Yeah.
They all need to be validated. And some of them won't make the bar. That's okay. That's what our regulatory systems are there for. But how can we do that?
And we learn from those failures every time.
Failures, right? So how can we quickly test those and then decide how do we use those technologies?
Get them implemented. Let's get it done.
Right. And in the right way.
Yeah.
So we may decide that a certain technology is a little bit more risky. We would only want to use those for stage 4 cancer patients, right? Because there's no other alternative this would be the best alternative. So let's use it here and let's see. And then we can better understand that. And maybe we can then see how we can scale that up to cancer patients that are earlier in the stream, right?
Well, and I look at some of the technologies that we've looked at with the Health City series, and I mean, in my mind, they're smaller scale technologies. Some of them, when we look at like the phone app systems where people can take their own control of their well-being and their health, and if they're spending less time in an emergency room or in a lineup at a clinic somewhere, and then that doctor has a little bit more free time now to focus on something more serious. We go back to your example on the gentleman that's testing 100 that are negative just to find the one that's positive when you could just put a system in place. Well, if we can alleviate the weight that's on a doctor of the runny noses, cough, I sprained my finger cases to the I'm having a heart attack right now and need to be taken care of, or you have found a lump that needs to be looked at cases. If we can separate those, I had an interesting conversation with an Alberta Health Services representative when they're talking about putting in like almost like a walk-in clinic attached to the hospitals now. So that way they can get assessed immediately when they walk in. Are you an ER patient that you've just sawed your hand off, building your tool shed?
Right.
Or are you a running nose case? And we can send you over there. And I feel like as much as that physical building, that physical location still needs to be there, the technology that we've been discussing kind of acts like that in a sense, where it's like, I have a runny nose, I have these symptoms. They can go on, they can dial up maybe a doctor who's sitting in an office somewhere and say, yeah, you've got the flu, like come in, get the shot, yada, yada. Or no, like you're missing an arm. You need to come in and get that fixed now. So there's this conversation of those technologies and those applications. How do we fast track? Like, I mean, because when you say crisis, I'm like, okay, like this isn't, a thing we fix tomorrow. It's something we fixed yesterday.
Right. We need to act now. So I like to go back to other sectors for examples, and banking is a great one. And the reason why I like banking is because when we think of security of data and privacy, it's utmost as well, right? And so, banking has changed significantly in the last 20 years. And so now, unlike the generation before me, unlike my dad, I manage my own RSP. Right. But I work with a particular bank, and I do all my trades online and so forth. But I have somebody that calls me once a year who has access to my data.
Yeah.
Right? Because they're a representative. And they say, hey, we're just taking a look at your portfolio here. You're getting older. Your kids are now heading off to college. There's some life changes that are happening here. We'd like to come and sit down with you and talk to you one-on-one about how do we look at managing your portfolio going forward, right? So I am still in charge of my financial health, but I need advice and I need guidance to ensure my ongoing financial health. We can use the same model in health, right? And so we have that ability to touch base now with a specialist, as you say, who could look and say, Reg, we're taking a look at your health. We're taking a look at your blood pressure that you're measuring weekly. We're looking at how much you're walking every day. We're looking at all these things. And you know what? We'd like to chat with you to optimize your health portfolio. In the end, I am making choices every day of how many Big Macs I'm eating versus oatmeal in the morning, how often I'm exercising or not, how well I'm sleeping or not. But I may need some guidance. I may need some help. I may need some advice on how to better optimize my health going forward. The better I'm in control, because I'm making those daily choices, the better my health is going to be. So we can change that paradigm. Use banking as a bit of an example to say, look, how do we do that? How do we manage now your health portfolio going forward in a smart way? Because you and I are making those decisions every day. There's not a doctor in the background going, hey, you shouldn't have that second donut.
And I mean, if you're in ownership of that data, you should be able to tell yourself, hey, I shouldn't have that second donut.
That's exactly
right?
it, right? So now if we have visibility
You're
into that,
educated.
right, you're educated, you know,
Yeah.
you can make
As
those
an individual.
changes, right?
Yep.
So now where the real value comes in is, say I've done that, I don't eat donuts anymore, and I think I'm eating healthy, and I'm eating my oatmeal in the morning, and I'm doing this, but I'm still not hitting my targets.
Yeah.
My portfolio is not working. That's where I may need to talk to a dietitian. That's where maybe even a clinician makes sense for me to have a conversation with, where I can sit down and say, okay, well, these are the things I'm doing.
Yeah.
It's still not quite working. I'm not either losing the weight, or I'm not controlling my blood pressure or my cholesterol the way I want to. What else is it that I need to be doing that I'm not doing, right? And that's where you might say, okay, well, maybe it's a little bit of medication. Maybe it is a change in this piece that we haven't even looked at.
Yeah.
Right? And that's how we start getting smarter about health. And then in the long term, what's happening is we're actually preventing some of these emergency visits because we're constantly managing that portfolio, our own health portfolio, on a regular basis. But what happens now, you know this, we don't see our data. And so,
Just
however,
throwing darts at a board, hoping to hit a target.
sure. And we go in and see a physician, maybe it's a family physician once a year, who takes a look and says, well, your cholesterol's high.
Yeah.
Okay. So
Change your diet.
Right.
Okay.
But you know what happens is that we usually are not too bad, Bryce. We visited the doctor. She said, change your diet. We change our diet. But then we don't get feedback. Like, so I've now done this for 2 weeks.
Is it the right thing?
Is it the right thing? Am I doing the right thing? Do I get that
now,
feedback?
if you were
right?
digitally monitored,
there you have it.
your doctor could call you up and be like, hey, man, like, we notice your blood sugars are a lot lower. Good job. Like, whatever it is you're doing, or like
doing.
that diet that you've been doing. You know what? Instead, let's change. You don't eat blueberries, eat this, whatever, right?
Right.
Can you imagine? And we've kind of already done this before we close. And I don't want to I'm thinking Star Trek because I like the future stuff. But when you look at, there's those fall arrest systems. You know, like if you've fallen, you can hit the button, it calls emergency for you.
Right.
Can you imagine? And I mean, you hear about these cases with cancer. You hear about these cases with triple bypass surgeries on heart attack victims or heart attack cases where they come in for one thing and by accident, it's like, hey, man, like, you know, the reason you have these headaches is because you have a tumor. Right. Or, hey, man, the reason you're having trouble breathing is because you've been having micro heart attacks for weeks, right? Mm-hmm. Can you imagine getting the phone call before you've had the heart attack? So your doctor, your clinician has that data. I mean, we talk about this and I'm going hypothetical here. I don't want to freak anybody out with the possibilities of future. But can you imagine getting the phone call? I mean, we have the Apple app where it monitors your heart rate and your pulse and all sorts of stuff. But if you got that phone call all of a sudden, it's big, hey, like, we've noticed a spike in your heart rate. I think you should come in and get a checkup. And you show up and they're like, yeah, you have a clot that we would have not been able to detect. Now we're being proactive to emergency situations.
Right.
Wouldn't that be cool?
Well, you know what? And honestly, I think we either have that technology in many of the cases or we're very close to it. Because what you're talking about here is looking for those anomalies.
Yeah.
Right? And so if we could do a full set of monitoring that's non-invasive on a regular basis, we could start looking at, hey, this is an anomaly, right? Reg's arrhythmia or his heartbeat is looking different than it usually does. You're not going to have a machine diagnose that necessarily. We could get there.
Yeah.
We're not there yet.
Right.
But we do have enough of technology to go, that doesn't look right. So before we get into an emergency situation, can we bring that individual in? Can we run some more tests? That's the time to do the tests. What happens now is that something happens, I'm at dinner, and then all of a sudden people go, I think something's going on with Reg. We got to get him to emerge, right? And then we backtrack and we run a bunch of tests. But you're right. I mean, we have the ability to do this today. So that's where we start to form a new relationship between us as individuals and our health system to partner ourselves on care so we can be preventative and start looking at these early signs because we know what they are. Mm-hmm. What we're not doing, though, is monitoring them because it's actually very interesting. Like we go for an annual checkup and do a check every
Once
year.
a year
once a
if you're lucky,
right?
yeah, and that's if you're
But
smart.
but even our vehicles are constantly monitoring all the time. What is the temperature of our engine? How much oil we have? How much fuel we have?
It's a good
what the tire
narrative to think
pressure
about,
is,
and
right? And that's constantly telling us
Yeah.
this is what's happening. My vehicle right now, even if I lose a couple of PSIs on my tire, it notices. It says, well, the back left one is 2 pounds less, PSI less than the other tires.
Yeah.
Are you going to do something about that? Right? Now it's up to me to go in and fill those tires or whatever it might be. But if we're monitoring our cars, why wouldn't we monitor ourselves?
Yeah. Yeah, because this is the most important engine that,
Absolutely.
you know, at the end of the day, and it was something I was going to lead into, I never got to, but, you know, of all the things that we should be caring about the most, because at the end of the day, whether you're a millionaire, whether you're, you know, an evil bad guy, whatever, your health
is the most important.
is the one. You'll drop anything and everything to take care of that health. If all of a sudden you got that call that's like, hey, like, you got a problem. Okay, drop it all. Or if your kids, right? Like you think of your kids, and so it's an interesting conversation. This flew by because I think there was like about a dozen things that we could have jumped into. I think we might have to do a part 2, but I mean, there's a dozen conversations that we could be having around. You know, like I like how the non-invasive. You know, where does technology look like in that sense? I think we got a really good picture of. We kind of did and we kind of didn't. I still want to really get into Health City and how you're bringing people together and how that pictures. We're going to do a part 2 because I think we're going to have to diverge into that. I really want to talk about how because you guys are doing some really cool stuff and you guys are doing some awesome advocacy. And before we get to part 2, for our listeners, be sure to go and check out the Health City website, find out more information about you guys and some of the great work that you guys are doing, because it is really great work and it's important work that needs to be done to get us out of this crisis, because it is a crisis. And I agree with you 100% in regards to that. When you look at the numbers to the results at the end of the day, there's got to be a shift and that's got to happen.
Absolutely. Looking forward to part 2, Bryce.
Good stuff. Right on. Thanks, Reg.
Thank you.
You bet.